Good morning, everyone, and thank you to Diane who helped navigate this and also provided a lot of the information that I'm going to present. So I'm going to share my screen. Let's see if we find this again. All right. And let me turn it to the slide presentation format. And I need to start at the very beginning, not slide 7. Okay, pardon that. All right, so I thought I would first do a situation summary just so that start with this overall situation. So through week of April 9th, 2022, Northern Virginia, the region is at high COVID-19 community transmission. That's using the previous metrics that CDC had, and that relies on case count and test positivity, and we're still following that. The week going through April 7th, 2022, using the new CDC metrics, Northern Virginia is at low COVID-19 community impact levels, while Arlington is at medium. And things like that have occurred in the past where we sometimes are better than some of the other jurisdictions in Northern Virginia, and sometimes we're worse than other jurisdictions in the area. And so, and I'm also happy to send the slides so people don't have to try to take pictures, but I also understand it could be kind of small. So, so this has been something that's happened throughout the COVID pandemic. There's no specific pattern that you can say one community is going to start before another. It just is going to be the characteristics of the virus and the people in that particular area. So, and I'll get to the specifics about the new metric. And the other piece that I wanted to talk about is vaccination progress through April 10th. 87.6% of the Arlington residents 5 and older have at least one dose of vaccine, which is significantly high compared to a lot of Virginia and the rest of the nation. And then among the 5 to 11-year-olds, we're at 67.3% with at least one dose of vaccine. So that's good. I'd like that number to be better, but when the conditions change, interest in vaccine can change as well. So it's just one of the things that happens. This is a dynamic situation, and people don't find the threat to be as significant, then they may be more hesitant, especially with children, to get them vaccinated. So just wanted to show people what the new metric looked like. It's a little complicated, so I just wanted to walk people through it. It first starts off with the number of new cases. If on the my left-hand side, new COVID-19 cases, whether it's under 200 or above 200, when it's under 200 or over 200, the next indicators are the number of admissions per 100,000 population over the past 7 days, and then the percent of staffed inpatient beds occupied by COVID-19 patients for both. And for the longest time, the whole region was in low. The rest of the region is low. We are technically in the over 200 mode with the so that makes it automatically medium. There's been essentially no change in the admissions to the hospital or the staffed inpatient beds. However, let's go back. One of the things I wanted to point out is this metric is based on the number of cases that comes in, and some of the things that we've recognized that people don't always recognize is that there has been ongoing transmission of COVID. Just because they changed the metric and said it was low, and I'll show you the previous metric, we've had ongoing transmission. Shouldn't come as a surprise because we're still in a global pandemic. 2, in the last week to 10 days, we've seen an increase in testing, which is not surprising, especially as spring break and travel for religious holidays, people may be preparing. And so it's not suddenly that there's an increase in cases, but as you all probably remember, asymptomatic infection is actually a very strong component of COVID-19. So I'm going to assume that all of us potentially on this call all have COVID. But unless you get tested, and there's no reason to go out and get tested all the time, But when you do testing, especially proactive testing for travel, you will detect things that were already there. And then obviously the final thing that some people aren't aware is there's often a delay in the reporting of test results. And we're actually still receiving test results from before March. That's just how the system unfortunately works, is that some of the test providers have really poor systems of getting the data back to the states, which then gets it back to us, so that some of the increase can also be to delayed reports. We try to remove that, but all three things can be true. You have some or increased transmission, you have early detection through testing, and late reporting. So my focus has always been on reminding people, while there's transmission, you need to actually think about the risks you're taking and how to minimize those risks, especially as we all get older. Older individuals are at more risk, unfortunately, for the complications from COVID than people who are younger. So CDC color codes the activities you can do related to the community level. When you're at low, it says to stay up to date and get tested. If you're in the medium range, if you're at high risk for severe illness, talk to your healthcare provider about what you can do. And then once again, the other two categories. If we get to high, we would recommend that people wear masks indoors and stay up to date, get tested. And as I've told people, some of you may want to take the precaution of wearing a mask all the time. Only you know what your circumstances are, either for yourself or who you will be protecting in your life to reduce exposure risk. Because if there's asymptomatic transmission, it's still possible, and we are seeing an increase in transmission, we don't know who is at risk for exposure, and then who they may be protected from by the vaccine, but even vaccine's not 100% foolproof. You don't always want to keep exposing yourself and seeing when that immunity may not be as ideal. So just things to keep in mind. And this is just a way to show both of those graphics together, showing that once you determine the color, you can go to the prevention steps. So this is one way some of you have seen us present the COVID pandemic since the very beginning. And so this is from at the very beginning of this chart on the left, starting in March 2020. This goes all the way through April 13th. And this is the entire pandemic curve of the cases that we've had in Arlington. And when we were doing this back in March of 2020, this peak that was 303, which is tiny numbers, this used to be a much higher peak in a sense, because we didn't have the subsequent peaks that were actually higher. But I want to remind people that this does not tell the entire story. Yes, we saw this very large peak in December and January of this past year, but the deaths that we were aware of, that all of you, and I know it's scarred the staff and me continuously, the majority of the deaths occurred in 2020 and were around this peak time. So we've had about 321 deaths. I think we're up to 322. More than half of those deaths actually occurred in 2020. And unfortunately, the majority of those deaths were in older adults, and at least half of those were in nursing homes. And so, and I'll get to the reasons why. And so it's just a perspective that graphics are good, but there's a context with all of this. And as you can see, there's been an uptick in cases again. This is the color coding of the previous system, where the lowest category would be one in blue, low, the next category in yellow would be moderate, the next category is substantial, and then the salmon or pink is high. And we as a region, and Arlington had dropped down into the substantial range, but we've gone back up into the high. It's just pointing out that germ is present. It doesn't necessarily tell you anything about how serious it is, but Omicron, the reason why it's so high is because relative to the other variants, it was even more contagious. So it's not surprising that you're going to have a significant rise, just to put things in perspective. And for those who like numbers, try to show you the Arlington data versus the Northern Virginia data, the metric for community level and community transmission level metrics. You can see as I said, we moved into medium on the new CDC metric, but for all of Northern Virginia, including ourselves, we're still at low. That's the perspective I ask people to really take, is germs don't respect jurisdictional boundaries. So we need to keep in mind that the larger picture, and overall, we still have the bed capacity to be able to sustain and survive a large outbreak. But I'm of the opinion, why test the system? You're going to keep hearing from me, as much as possible, each individual should do as many of the layers as they can to protect themselves and others, to reduce germ transmission. But the point of the other metrics on the community transmission levels that were in high is just to remind people, we still have germs here. We still have a global pandemic. So moving on to the next slide. This is from our COVID website, our dashboard on generic or non-vaccine data. And this has not been updated since March 31st. It's not because we don't want to, but we rely on the state for the data, and the transfer of data has not been as smooth in the last several weeks, and we have to reestablish those things. The state is working on their websites and changing how they're reporting data, which then of course affects us, and we have to make sure it's accurate data. Fortunately, we have other systems, and so that's why I showed you that other graphic about the number of cases, in a sense. But yes, we are reliant on the state systems operating in a certain way. If they change, that means we have to change ours, and so staff are working with our IT systems in the county to try to reestablish the proper connections and make sure that the data is correct. The overall picture is, though, that we still have the issues that we have, but you can go to our website to get summary data, typically to get this information. One of the things that's on our dashboard, you'll see the zip codes where cases have occurred, and the large point that I want to show is, first of all areas of Arlington have experienced COVID-19. However, some areas have experienced more COVID than others. The deepest orange has the highest cases in proportion to their population size, then the lighter orange, then the light blue, and then the dark blue, which has the fewest cases in proportion to their population size. The average for Arlington rate is 16,652 cases per 100,000, which essentially puts us right at the border between the light orange and the light blue. And so you'll see that the swath of orange is essentially along the Roslyn-Ballston corridor and into, as well as the Columbia Pike corridor and surrounding those areas. So something to be aware of. So cases and deaths by age group. This is the thing that haunts, will continue to haunt me. We recently, Diane and I went to the county's memorial service for the 2-year anniversary, and recognizing the 321 people at that point that we knew had died from COVID. And it's still just a dreadful thing, especially in the nursing home and assisted living communities, where it's not just a COVID-related phenomenon, but how we do this sort of care, not just here in the Commonwealth, but across the nation. The disease burden has been highest among those 0 to 19 years and 20 to 39 years of age. That's what the first graphic shows. But the deaths have been disproportionately impacting our older adults, especially residents 80 years and older. And so just that graphic alone, I think, is just tells us a lot. And at least 50% of the deaths occurred in nursing homes in the first 6 months back in the pandemic in 2020. This just illustrates the power of exposure. When you can't control your exposure because you need assistance from others, and especially at the beginning when we had no vaccines, people who need help with their activities of daily living, which I know your organization in many ways provides that service. Like if you provide transportation to others, that's a type of activity of daily living that people need. And if they can't do it by themselves, you're reliant on people, and those things usually can't happen without being within 6 feet of each other. And so how do you reduce exposures when that's important? So there are obviously things that can be done, but often that would require requirements and legislation. And it's not just here in the Commonwealth. The appetite across the nation for those sorts of things isn't always great, especially if there's going to be financial implications for those things in the long run. So just wanted to make sure you're aware of that, and we can always discuss what your roles can be in that. Cases and vaccination by race, ethnicity, trying to combine several things at the same time. So as I said, you'll get this data, but the summary important data is in the blue box in yellow lettering. While almost 16% of residents report being Hispanic, they represent 20% of the COVID-19 cases and only represent 16% of those with at least one dose of COVID-19 vaccine. Almost 61% of Arlington residents are non-Hispanic white. They represent only 39% of the COVID-19 cases. It's not that I'm wishing that there would be more, but it's to show the disproportionality, and it could be related to their exposure risk. And yet they constitute 50% of those vaccinated to date. I would love everyone to be proportionately vaccinated and as close to 100%, and we'll show you on the next slide some of that data. So on this busy slide, it's taking all of the age groups and trying to do them for the most part in 10-year categories. For the younger groups, it's a smaller grouping because it's related to also how the vaccine was rolled out. And you'll see that vaccine is available to those 5 and older. I'll get to the information about when we're thinking about seeing the vaccines for those under 5. The vaccine for those 5 to 11 years of age has only been available for several months compared to all the other groups. And I have to tell you, we are doing very well compared to the rest of the state in Northern Virginia, but that's still not good enough. Obviously, we'd like it to even be better. To supplement the central activities that we have at Walter Reed Community Center in Arlington Mill, the county has been working with the Arlington Public School System to identify the Title I schools and those with large free and reduced lunch eligibility to offer vaccine clinic after school hours, but at those schools to reduce the barrier to getting vaccine. But as I've also said, with the pandemic seeming to be under more control in some people's eyes, the likelihood it'll be harder to convince people to get vaccinated. That is a common phenomenon, and this is where I rely on all of you. Diana and I work for the Talking Head Agency. I'm the official talking head. We are not always going to be the most effective individuals. We talk to all of you. You're the ones who actually know people in the community of all different stripes, and it's those ripple effects that we're hoping for. If you believe what we're saying and you then can share it, you may convince people who are on the fence to move in the direction of getting vaccinated. That's why it takes a village, really, honestly, to make this happen. And as to reiterate, it will be harder with less disease and some level of vaccine hesitancy to get the remaining individuals vaccinated, especially when parents always want the best interest for their children. But one of the things I want to show you is that outside of those 85 and older and those under 12, every group age group is at least at 80% with at least one dose of vaccine. And I need to tell you, even when that's true, when you look at those 25 to 34, close to 81%, when you look at the very gray area, that shows all of the people who are unvaccinated. They're still close to 11,000 people unvaccinated in that group based on our data. So I am over the moon about how well vaccinated we are. And when you're not over 95%, you still have a lot of people who can actually get the virus. And if it goes the wrong way, they can have serious illness, hospitalization, and even die. So, and we're in a good place, and that's true even for Northern Virginia. But if you think about it, the risk to those individuals as well as to the whole system, healthcare system, is you still have a lot of people who are unvaccinated compared to other places. We're doing so well, but I'm not going to rest on that laurel. Let's go to the next slide. So a way to think about the barriers to vaccine, and just in some ways about what people believe about COVID in general. There are those who are enthusiasts. There are those who are hesitant. They're unsure but persuadable, often because of things like they're watching to see how others are doing. So we still get people coming in for their first doses of primary vaccine because they may have finally said, okay, I've seen enough and I think it's safe, or I've seen too many people get affected, now it's my time to get it. There are those who still believe they're cost anxious because they think that the vaccine may cost them money. It won't. But if you're a person who can't take time off from work, then that is money you lose if you have to come get it. That's why we try to have different hours and do it on the weekends. And then also, just given our size, we have over 30 pharmacies across the jurisdiction that are providing vaccines. So that's a lot of places where people can get it, but still these sorts of barriers can happen. And also, there are systems distrusters. People don't always trust medical or government establishment, but they may not be anti-vaccine. And then there are those who are COVID skeptics. And if you look at any of the national data, roughly it seems to be about 16%. So we've actually done better than that in Arlington, but we just have to realize that there are going to be people who are COVID skeptics even in Arlington, and that's just something we have to recognize. It's not related just to COVID. And what do I believe the hesitant and the COVID skeptics likely have in common? Trust, or the lack of trust. And so honestly, that's where you all come in as well, because I am convinced you are more trusted than we are in government. And the more that you can actually spread the word and do it in a non-judgmental way, you're part of the public health system to help people understand what's going on. And as I said in a video that I made about the vaccine, I'm not trying to convince everyone to get it. I just want people to have truly the right information to make the best decision for them. There may be good reasons, personal reasons for people to not get vaccinated. I'm not going to judge people for that, but I don't want people to not have the information about the vaccine. And with millions and millions and millions now getting the mRNA vaccine especially, but even the Johnson & Johnson, the overwhelming evidence is that it's been safe on population levels. And so, and people just have to get to the point where they can trust it or not. And I always love this graphic. There are two reasons why we don't trust people. First, we don't know them. And second, we know them. And I think that sums up kind of the issues that we're dealing with even here in Arlington. So I think this is an important point that I've kind of implied throughout this. COVID exposure and COVID complications, they're two different types of risks, and they're basically what is true about any infectious disease circumstance, or non-infectious disease if you're talking about things that put people at risk for health. So talking about exposure risk, I'm talking about your risk for being exposed to COVID. So in my simple way of thinking about it, there are those who are less at risk or impact of exposure. There are those at average risk or impact of exposure. And there are those at increased risk or impact of exposure. And with COVID, those who are at less risk or impact of exposure, it's going to be those who can stay at home exclusively, those who are vaccinated and boosted. Those who are average risk or for impact of exposure, they don't live in a congregate care setting. They're not considered essential workers. They're able to maintain 6-foot distances to perform activities of daily living or work. And those at increased risk or impact of exposure, congregate care settings. essential workers, those who cannot maintain 6-foot distances to perform ADLs or work, or the unvaccinated. I want to point out that last category. Back in the beginning of the pandemic, all three of those things would come together. I mean, all four of those things would come together in congregate care settings where you have essential workers, people living in those places. The workers and the individuals can't maintain 6-foot distances. And at that time, they're unvaccinated. And those relative things, the unvaccinated portion has improved significantly with vaccine. But in those settings, whether it's COVID or other illnesses, if that's how exposure occurs and transmission occurs, those are essential parts of those systems that can't change. So you need to engineer those things to be different. And that's going to require societal things to say, you know, we don't require wearing personal protective equipment, say, during flu season necessarily. That's a policy decision that has to be made either voluntarily by a facility or society has to mandate it. But there are costs both ways. So have to keep that in mind. So one of the things that people also need to recognize the way we think in epidemiology is who's at risk for complications once you get infected. And once again, you can put it in the three buckets. There are those who are less risk for or less impact from complications, those at average risk, and those at increased risk. So theoretically, those with healthy immune systems, it's hard to prove those things, but you know, we know there are those who have more robust immune systems than others, and those who are vaccinated and boosted. Average risk would be those without chronic medical conditions and those in lower age groups. We know that the youngest for COVID have had the least risk. That doesn't mean they don't get COVID, but they've had the least risk of exposure and they've had the least risk of having complications, although there are always caveats within that. And finally, increased risk of complications, those with chronic medical conditions, those with increasing age, those with both chronic medical conditions and increasing age, and of course, being unvaccinated. So this will never change on a relative scale. The absolute risk may be different, but relatively speaking, these are conditions that are existed before COVID, during COVID, and will continue after COVID. Public health always tries to argue for what's the public appetite to engineer out some of these exposure risks and complication risks, especially if you can't change the complication risk, can you then engineer out the exposure risk? But those are public policy questions that are not left up to me as a doctor. Just like if God forbid one of you has high blood pressure or a cancer diagnosis, the healthcare professional should be telling you all your options, and you need to be the one who makes the decision of what precautions and what treatments you want to take, or do none of those things. That's that informed consent piece. On a population level, it's the heads of your various organizations, whether it's government, non-for-profit, or business. They're ultimately making the decisions for what's best for their customers and their employees, two different population groups, as well as the original purpose. So things to think about. I think this is probably where some of you want to know some of the information. You know, what's next for our community short term from my perspective? So first of all, you know, we've heard that more boosters were recommended for those 50 and older by CDC. Moderna is expected to submit vaccine data for children under 5 sometime in April. Let's hope that is on schedule. The FDA postponed review of data for vaccines for the same group until Pfizer could submit third dose data, and that's going to be hopefully sometime in April. And that's going to be an interesting thing if Pfizer recommends 3 doses and Moderna recommends 2. You know, may take a longer time to get children vaccinated if more people choose the Pfizer. We still are continuing to recommend to get additional doses if you're immunocompromised. We're still waiting for results, you know, ongoing to see how effective the vaccines and treatments are against Omicron variants, because we are not doing randomized controlled trials exposing people. We have to see the natural experiments out there. So of course it takes time. I don't want to be a downer, but I have to remind people, We have additional COVID variants are always possible until the majority of the world is vaccinated. I can't imagine that's going to happen until at least the end of 2022. When I last did this, and this was last updated in February, only 62% of the world had received at least one dose globally. And with a population of 8 billion people, that's a lot of people we still have to, whatever that difference is, that's still a lot of people who need vaccine. So we continue to recommend using as many strategies, which we refer to as the Swiss cheese model, and you'll see it on the next slide, so that you and your loved ones can reduce the risk of continued exposure. Because, as I've said, no vaccine or other strategies is 100% effective. However, having said that, we have vaccine testing and treatments to help better tackle COVID-19. And as I've said, we have good hospital system capacity, especially in the Washington, D.C. metropolitan area. And I implore everyone, we don't want to unnecessarily stress that capacity. Just because we have the capacity doesn't mean we should be trying to use it. Some of you have seen this Swiss cheese slide before. Basically, use many strategies to slow the spread of COVID-19. No single strategy is perfect at preventing the spread of COVID-19. Each strategy has holes or weaknesses. The more layers you use blocks more holes. It's how you can reduce the risk of exposure to yourself and to those in your life, those who are immunocompromised, those who are older. And then this is kind of my closing sort of crystal ball for the future. So what's next for our community and kind of the nation in general? Assuming no further variants and we have more vaccination, we're going to be moving to COVID endemicity. There's no indication that COVID is going to be going away at this point. It's going to become like flu. We just have to see what the pattern will be. Will it become seasonal and truly just in the winter months like flu, or will there be two seasons? We don't know, and that's why we just have to see the patterns that develop. But given where it's going, we've moved publicly, as CDC, VDH, and Arlington to a more outbreak management profile, which is what we typically do for flu, and we do surveillance through hospital and physician providers. We don't try to capture all the cases because you don't need to capture all the cases to know something's present. And then as you see the increase and decrease, even if it's not the absolute number, you can do recommendations based on trends. Other things that everyone needs to do, and we'll be doing that as well, is revising our pandemic emergency preparedness and response plans. A prime example is I never thought I'd live through and have to be running a health department through two pandemics. H1N1, our efforts were for vaccination, for example, were in the schools, but given that 6-foot distances were needed and schools were needed the spaces we would normally use for providing those vaccines, like their gyms or cafeterias, but they needed it to press those into service for those for education and for and feeding. Suddenly, not just Arlington, but the entire nation, almost all of the plans were built around schools. Fortunately, we had community centers, but they're not in the same, distribution, obviously, as schools. So, the reality is this is who we are, and we're going to have to update those plans and rely on those centers. And also, information access was not easy when everything is digital and not everyone has digital access. And my final things really are about a lot of what we've been seeing, and this is not unique to COVID, but when values clash, do we value equity? Are we in the equality of opportunity camp or the equality of outcome camp? How do we get ourselves to the latter? Because honestly, we see differences in where people live and who they are that put them at more at risk. And the reason why, from a selfish perspective, it's like resiliency. We're only as strong as our weakest link. It's where we have our Achilles heel. It takes a village to run Arlington, and at all income levels, all diversity levels, and so on. We're only as strong and able to respond if everyone is strong. So keep that in mind. I think this crisis has shown there is such a variability in people's risk tolerances. And that's not something I think people, I think public health folks understood it, but the community has really understood that even within families, people's risk tolerances are different. And until we can civilly discuss that and come to something, it's going to be a clash, and it shouldn't surprise anyone that there are different tolerances and then different outcomes. And I've mentioned this finally, it's trust. How do we develop that trust? I think Arlington has done a good job, but does that mean it can't do a better job? Absolutely it could. And it's going to take all of us to do that. As I've said, we can lead in some ways, but you're the leaders as well, sharing your experiences and helping maybe personalize what it means for the more marginalized in our communities based on age, for example, what their struggles are. When you tell the stories, you're going to amplify the messages of the people that you serve. So with that, I'm going to be happy to take questions. I apologize if I ran a little long.
Anita, can you take over and read the questions?
Sure, Gary. So going back to at the beginning, you mentioned that people who have a chronic medical condition should be especially vigilant. Could you just clarify what are some examples of chronic medical condition?
So chronic medical conditions, great question, are things like lung disease. So if you've heard of COPD, chronic obstructive pulmonary disease, that would be a chronic medical condition. And chronic, of course, is not the first day, but of course, the number of years you've had these things will increase that risk. Congestive heart failure, kidney failure, those sorts of things qualify. And we can always send links to the CDC page that will show that. But one of the things that, if you're taking pills, there's a higher likelihood that you have a chronic medical condition. And honestly, it's one of the things that I'm encouraging all of you and the people you serve to talk to your doctors to understand, does this mean I have a chronic medical condition? Because I have a feeling the problem is I can't, unfortunately, talk to everyone in the community. But if you go to your healthcare providers, they can help say, yes, you would be a person considered to be having a chronic medical condition, because we try to lump things under that rubric, but there are so many diseases. So if you're undergoing cancer treatment, you're going to be having a medical condition that puts you at more risk for immunocompromised state, for example. Very
good. I like that advice to ask, does my condition qualify as the chronic medical condition that I see in the press? Can we go back to what the county provides in terms of tracking the data? One of our early questions in this talk was whether the county COVID dashboard is up and running as of, it was still under construction on April 4th, which is now a couple weeks ago. The most recent data was March 31st. Is the data going to be updated and the dashboard workable soon?
Sure. I'll repeat what I had said earlier. We know that there's been a delay. Part of it is that the state has changed its data feed, which means the county has to figure out how to capture that and if it can still be captured in the same way. We were trying to automate it so that we didn't have to do manual data entry. So we don't know if that's going to happen. The state has, I'm just going to imply, they're trying to move away from focusing on COVID and normalizing things. So we're trying to adapt to that, but that's going to take a little bit of time to know what are reliable data sources to have a more automatic feed. But there are other updated aspects of the data on that dashboard. That particular summary one is still old data, relatively speaking, but you can still see like the vaccine information. You can see the neighborhood information so far is still up to date, but obviously the summary data is not currently up to date.
Very good. The Arlington's recent status as medium is higher than other parts of the DMV, and you did explain a lot of the reporting issues there. But one of the questions we had is, could that be because more people in Arlington are reporting positive results, especially in their home tests?
Good question. We don't get most home test results. It's not Arlington specific. That's just how that testing has been done across the nation. There's no requirement. How do you actually force people in their homes to report it, first of all? And then there has to be a mechanism. This is all new in the public health world and in this nation. So we assume that what we're seeing, if we're already seeing high with what is available, we're going to assume that there's more transmission. That's what I normally do. A lot of people that go, oh no, I need to know it to take action. This is where I hope you trust going, look, if you already see disease and you know there's underreported, the likelihood is it's actually the same, if not higher. And so that's why we comfortably are saying, we know it's not rocket science for me to say, look, we see it across the globe. We're seeing spikes places. We know that we're seeing a steady increase in that undercounted reporting. So all of that would be reasonable to say there's ongoing transmission and it is increasing. And then in addition, for the public reporting sites, we know more people have gone to, we have the curative sites that we contracted with. And so those do report, and we know there have been more people going to those sites. And if you're testing more, you're going to at least detect more baseline disease, if not an increase. So you're seeing the issues with data in healthcare reporting. People have a right to hold on to their data.
Will the county offer antibody testing at some point?
No, no one's really recommending antibody testing. There are people who seem to be interested, and so you can get it in through your doctor's offices or through some of the pharmacies if that's something that you would like to do. I just caution people, what's the purpose in that? Because I think some people go, okay, I've had it, I won't get it again. Okay, that's not necessarily true. But if it's important information that you just want to know, was I exposed? It is a way to detect a point in time, but the antibody levels change over time. And so the lack of an antibody detection doesn't mean you may not have been exposed in the past. Sometimes it disappears, but that doesn't mean that you don't have immunity. And if you're trying to figure out where was I exposed, the only time you're really going to be able to know that is either the positive test or soon after symptoms to see, was it elevated? So once again, talk to your doctor or other healthcare professional about why you're pursuing it. If it just makes you feel better, I'm not saying don't do it, but just make sure you understand what's the purpose and still take precautions, because you could be exposed and you may not get serious illness, but we don't know the impact of long COVID either. And re-exposures could still put you at risk based on what we're seeing to this date.
Do hospitalizations on your chart, as you keep track of hospitalizations, only count Arlington residents, or is it anybody that comes into the Virginia Hospital Center?
So what we're doing on that dashboard is Arlington residents, not Virginia Hospital Center, because as I said before, our residents go all over the place. So we're also taking data from, we will accept data about Arlingtonians who are hospitalized in DC or at Inova and so on, because it's trying to paint a picture of what's happening for Arlingtonians. The healthcare system is being tracked by the state, and that's why the CDC has the information roughly to say what's the capacity at the hospital systems in general. So it's not just Arlington Hospitals or Virginia Hospital Center that is being considered, because as I said before, for some of you when we started, our healthcare system involves the entire Washington, DC metropolitan area. We know people are getting care as far into Maryland, into DC, and further south into Virginia as part of Northern Virginia.
So on the data regarding vaccination by age group, even though the number was very small of the number of people over 85 that are and are not vaccinated, it was a larger percentage of the people over 85 that are not vaccinated. So can you explain or have any sense of why the drop off for the older people over 85 compared to almost everybody in the 75 to 84 age group is vaccinated?
Will just be speculation, but as I said, people have different levels of trust and beliefs about what their exposure risks are. So if you have ideas or ways that we can get to those individuals to convince them, but we know that people not everyone wants vaccine. It's surprising, but when I really think about it, maybe it's because I think it's surprising because I am in medicine and I actually trust it, but that doesn't mean everyone has that same shared belief. And if you actually believe the vaccine provides you more risk, whether that's true or not, it's true to that individual. So that's why, as I've said to all of you, if you interact with some of those people 85 and older, engage them in conversation to understand what they're thinking. Don't berate them and go, you need to do this, because they've done well. Somehow they've done well. Maybe they really have amazing immune systems, but we won't know that. I still think they should get vaccinated, but I'm hoping you can communicate to some of those folks and just like, if you haven't gotten the vaccine, I could always take you there. And maybe what's the barrier? Can we get you some information? So please, whatever you can do would help as well.
We have about 6 minutes here and several questions. So a group of the questions revolve around the second booster. People are interested in possibly trying to time the second booster. I heard on the news that the booster is more effective for 30 days after the shot, and then it drops off. Is the drop off significant after 30 days after the second booster? On a personal level, they're trying to time it for a family wedding. Another related question is, I plan to go to my college reunion in May. I had my booster in late December. Do you suggest I get another booster? Another question is there any, for individuals 80 and over, is there any reason not to take the second booster now? What's the recommendation regarding timing? So it's really.
Sure. So yeah, so timing is going to be a personal thing, because I'm going to have to take a few minutes to explain some of the things about immunity. So a lot of the studies that they're doing immunity on is checking for antibody levels. The problem with that is we know that immunity wanes on the antibody level of what's physically detectable in the blood, but there are two immune systems markers. One is antibodies produced by B cells, and then the T cells are the ones that provide the memory to create when you have exposures. Like when you have measles, you don't always detect it after weeks, months, or years, but that doesn't mean you don't have the ability to respond. But the problem is if you're looking for the antibodies in the blood, which is really all that's commercially available to be able to test, it does look like it wanes. Can't say it any other way, but that doesn't mean you're not protected. Because one of the things we've been fortunate to this point to be able to see is, remember, the vaccine was designed to prevent serious illness, hospitalization, and death. And so far, knock on my formica here, we have not seen a significant increase of serious illness, hospitalization, and death among those vaccinated. Okay, so it's a reasonable precaution to take the booster. I've gotten all the boosters that are possible to this point. I am over 50. I plan on getting the booster. I have to decide when's the appropriate time in my sense. Using just my thinking, normally as the fall months come around, I suspect we're going to see more people indoors and having to be together and in workplaces. I may wait till then normally, but I can understand the logic if people are saying, I'm going to a large gathering and I may want to be boosted to try to say my immune system is the most robust at that time. It's a logical thing. CDC has not provided any specific guidance. This is where, once again, your healthcare provider can maybe work with you and seeing what do you value and does it make sense, because there's no formula here. This is a little bit uncharted territory. Normally CDC would say, yes, you should do, or they're recommending, they've kind of done a soft recommendation allowing people over 50 to have this opportunity to get it if they feel it's necessary. Sometimes it feels like it's keeping up with the Joneses. Countries like Israel have actually gone ahead and recommended it, and there are people going, well, I want that same access. So that's part of what this is going on. So if it feels like it's a depends answer, it is, because it's a personal decision. However, I know what I'm encouraging my mother to do is, like, when it's time for her, like if she's going to travel especially, I'm going to encourage her to get the vaccine to have the most protection possible.
And so we've got only a couple of minutes here. Two questions. One, Is there a quick answer, possibly, anything about a nasal vaccine that would provide immunity at the point of impact?
We know that it's being worked on, but can't tell you if it's actually going, when it's going to happen.
Regarding the second booster, I have seen a little epidemiology suggestion that we might be better to mix and match. So if we had one type of vaccine for the basic 2+1 booster, should we perhaps get a different manufacturer for the fourth shot?
There's no official recommendation on that. We have said, get the vaccine that's available to you. And I do know that there are people who have done the mixing and matching. I think that was especially important with the mRNA and the types with Johnson & Johnson. The others, the mechanism is roughly the same between the two. The one difference between Moderna and Pfizer, at least for the adult doses initially, Moderna was 3 times the dose of Pfizer. So I think, just my own speculation, when you have a larger amount of mRNA vaccine given, you probably had a more robust response because it's 3 times what the Pfizer dose was.
Very good. Thank you. I haven't heard that. And then finally, and I want to mention that Diane has put in the chat box the link to the CDC website on what are the medical conditions that you make you a higher risk for severe COVID. So anybody who's looking at the chat box can copy that web link. We are also recording this, and we will put it on our YouTube, our new Arlington Neighborhood Village YouTube. And I'm going to, and then also Diane has put in the Arlington County COVID response webpage where you can access all of the resources in the data dashboard. One final question, and we really do appreciate your taking time with our group today, Dr. Varghese and Diane. This has been really informative. This continues to be a pandemic. We are not out of the woods, but we are managing to resume parts of our lives. And I think Arlington Neighborhood Village has done a great job in leading our community of older people here, especially in feeling concerned but not overwhelmed. And that's what we need to continue to help each other with. So how about those alerts on the phone? They seem to be working for some people, but a lot of other people say, I've got the COVID Wise app on my phone and I've never received an alert. Is it even worthwhile? So,
like anything else, it depends on how many people have actually opted in. So if the circle of folks you interact with and where you go all have the COVID Wise app, then you'll have more likely you'll get notices. It's also possible that people around you really don't have it. There's no way of knowing. We cannot force people to participate. So this is, once again, it's good information if you get the alert, but I don't want people to take the opposite message. Don't assume that you haven't been exposed. I take the posture, everyone, pardon me, but I think every one of you is infected as well as I am. And so I try to continue to be respectful of distance and try to ask people what they're comfortable with. And you will see at the Department of Human Services, we're still using masks, and I still use masks because, there are people who can't protect themselves in workplaces. And so I assume maybe I'm infected, so I'm trying to reduce any extra exposure that, because they don't need any more exposures in their lives.
Very good. With that, we're going to say thank you again. Next week, we'll be back. Arlington Neighborhood Village does this every week with interesting speakers. We're going to be looking at Earth Day coming up, and representatives of Dominion Power, Dominion Electric, Dominion Energy is really their brand. They're going to talk about alternatives to fossil fuels. So it will be interesting to hear about what Dominion Energy is doing with nuclear, solar, and wind. Thanks again, and we are going to stop the recording now, I think, Gary, and say thanks. Goodbye.